is Beach Talk Radio.
Good morning, Mr. and Mrs. America, and all ships at sea. This is your captain speaking, Mean Gene. Mean Gene. The following will be a test of the ship's whistle, the sonar alarm, the cable alarm, and the atomic attack alarm.
Live from Peach Time Out in the heart of Times Square, you're listening to Beach Talk Radio with Kim and Ed Ryan.
And welcome to episode number 108 of Beach Talk Radio. It's Saturday, April the 11th, 2020, and it is day 23 of Fort Myers Beach being closed to every single person, including the residents that live on the beach. And it's episode number 3 from our backyard studio, as opposed to being at Beach Time Out, which is really where we would love to be in Times Square on the beach, but it is what it is. And we have a super show lined up for you today, folks. And we're going to get right into it with Dr. Stephen Thomas, the Chief of Infectious Diseases in Upstate University Hospital. Doctor, thanks so much for coming on. We appreciate your time.
Thanks for having me.
Yes, and I just want to thank you and all the healthcare workers that are out there for tirelessly working to support patients and families who are dealing with this pandemic. So thanks to you and everyone, everyone everywhere that's dealing with this. So we appreciate you coming on and taking the time this morning.
Thank you very much. It's good to see the sun.
Yeah, we were just talking that you guys had a little bit of snow, folks.
Yeah.
Did you hear that snow they had up there?
Easter Sunday tomorrow, and they have snow still in upstate New York. But before we get rolling with the questions, if you do have a question for Dr. Thomas, you can type it in the chat box today, and we will ask him. We don't know if he can answer every single question yet, but we'll give it a shot. So Doc, tell us exactly what you do at the hospital, and so people know exactly what you're dealing with now.
Sure. So as you mentioned, I'm the Chief of Infectious Diseases. So I'm an adult infectious diseases physician. And so normally what I do is I run a division of healthcare providers who take care of people with infectious diseases. And then another part of my job is I direct an Institute for Global Health and Translational Sciences. And so what they do is we do research and development of medical countermeasures against infectious diseases. So things like vaccines and drugs and diagnostic tests. But my new job as of the beginning of March is we have a COVID incident command here to try to respond to what's going on. And I'm the commander of that team. So it's about 75 to 80 people in the hospital that all have very specific jobs to prepare for and to react to the COVID pandemic that's occurring.
So, Doc, the question that I want to know is, how do people know if they should go to the hospital or if they just have a cold? Because if they don't know they have it, which a lot of people don't because of the testing, then they could stay at home and it could get worse. And then you hear people dying. So what is the proper protocol to follow when you're not healthy, when you feel like something's coming on?
Right. That is a really good question. And the answer to that has kind of been evolving over time. So the first thing is that it depends on what we would call the local epidemiology. So what that means is how much COVID is being transmitted in your community, number one. Number two, how strictly are you adhering to the social and physical distancing policies and recommendations? So are you freely going out, interacting with other people, and could you therefore be at risk to have been in contact with someone who was infected? And then the third thing to consider would be, there are certain people that do much worse with this disease than others. And so it would seem that people who are older have the potential to do much worse if they get infected. So people over 55, 60 years of age, people who have pre-existing medical problems. So things like diabetes or heart disease or lung disease or kidney disease. So those are some of the things that should get you thinking about whether or not you should see a medical provider. Now, in terms of the types of symptoms that you may have, unfortunately, the symptoms initially we thought it's people with fever and cough and shortness of breath. But what we've been finding out as the weeks go by, it can be a mild illness. So people may or may not have fever. They might have gastrointestinal problems like nausea or abdominal pain or diarrhea. They might just have a sore throat. They might just have profound fatigue and kind of generalized muscle aches. So my advice would be, if there is COVID in your community, if you are certainly within one of those risk groups and you do not feel well, then I would call your medical provider. I would explain how you're feeling and get their guidance onto where you can go to be evaluated and tested.
All right. And as you were talking, there seems to be there seems to be categories of people. So there's even people that are going around that are maybe infected but don't have signs. Is that correct? Mm-hmm. So everybody needs to take precautions, and then there's other categories. Not everybody that gets it ends up in that 5% that's, right, really, really sick. Can you talk about some of the numbers and how that works?
Sure. Yeah, no, that's a really good point. So I like to think of it as an iceberg, right? And this is not unique to COVID. So the first thing I would say is that people, there's different terminology. So SARS-CoV-2, that is the virus. COVID-19 is the disease that virus causes. So you may hear both of these things. That's the clarification on that. So think of it as like an iceberg. And this is not unique to SARS-CoV-2 or COVID. This is how lots of viral diseases work. So think about an iceberg, and the majority of the iceberg is below the water. The part below the water would be the people who get infected and don't have symptoms, or the people who get infected and the symptoms are so mild that they don't even need to go to the doctor. So that's the bigger part of the iceberg. And that's typically the way it works. The part above the water, those are the people, that's the 20%, right? So those are the people that get sick and have a severe illness and need to go to the hospital, or people that get critically ill and end up being on ventilators or needing dialysis or things of that nature.
All right. And initially, when this, came out, there was a lot of people on Facebook and whatnot that were like, oh, it's the flu kills more people every year. It's just the flu. What is the difference between COVID-19 and the regular flu?
Right. So the first thing is that typically influenza is seasonal, right? So it's fall and winter and into early spring. So our season up here starts around October and can go up until April, May. That's the first thing. It's seasonal. The second thing is that it usually comes on much quicker. So people can feel well, and then they'll have fatigue and muscle aches and fever, and they may have runny nose and cough and shortness of breath. It seems that with COVID, it can be a little bit more insidious and it can last a little bit longer. So we see lots of people who, they don't feel great, but they're not really that bad for about a week. And then they kind of fall off this cliff and they can get very sick very quickly. But in general, it takes a little bit longer. So what you need to know about influenza is that the fatality rate from influenza is about 0.1%. The fatality rate for COVID is now, in the United States, it's hovering around 3%. So that is a huge difference. Influenza kills about 40,000 people every year in the United States. So you can do the math pretty quickly to understand the potential here. The other thing is that influenza, we think SARS-CoV-2 is probably twice to maybe 3 times as infectious as influenza. So it's kind of the double whammy in that you have something that is more transmittable, more infectious, and it kills with a greater frequency.
Doc, when we do other shows with the mayor and some other shows, we get people that are kind of arguing with each other about the numbers and things like that. But I was wondering, and we have a question here today, if I get it, does that mean that, and I fought it off and I didn't have to take any drugs or I didn't have to go to the hospital, does that mean I'm cool then? I don't have to worry about it? Or, once it's gone through my body, is that the end of it?
Yeah, so that's a good question, and it's a question we're trying to figure out the answer to. If we believe, based upon our experience with other respiratory viruses and based upon our experience with SARS-CoV-1, so that was the SARS outbreak back in the early 2000s, based on our experience with MERS-CoV, which is another coronavirus, we do believe that if you are infected and you survive, that you probably have immunity, which can protect you either from reinfection or disease following reinfection for at least a short period of time, a couple of years. That's the expectation, but that But to definitively understand that, we have to continue the research that we're doing and follow people who have been infected, who have recovered, and see how it plays out.
You're gonna pop that question.
Yeah, I'm going to pop a question up from a viewer in a second, but what you said got me thinking of another one. How did the United States miss this? How does a country like ours miss something like this? So now the economy is totally shut down.
Yeah, so that's a really good question, and that's a question full of lots of political minefields, right?
Okay.
So what I can tell you is that the United States, for decades, has been investing heavily in pandemic preparedness. They have been investing heavily in what we call kind of a more general biopreparedness. You can remember there was a huge investment after 9/11 and the anthrax attacks, not only in biodefense, but also in the defense against just naturally occurring infectious diseases, emerging infections, re-emerging infections. But the thing is, it takes a lot of political will to sustain these programs. It takes enduring funding to sustain these programs. You need to have a continual replenishment of subject matter expertise within the government and within the community. It has to be a priority. This was both, presidents, and I'm not getting political, I'm just stating facts, that past presidents have looked at infectious diseases as a not just a health threat, but a national security threat.
Mm-hmm.
And again, there's been many examples of huge tabletop exercises that people have, that the government has sponsored or participated in, looking at scenarios such as this. I'm not in the federal government anymore. I don't know what kind of conversations occurred. But we are where we are. Probably not productive to look backwards yet. Probably more productive just to kind of focus on the now and the future and what we can do to try to minimize the damage here.
So we'll go to the question from Jill. Once we're all able to get back out on the streets, will we all get infected? Can you talk about herd immunity?
Oh, Jill, I love that question. So herd immunity, just to kind of explain, if I receive a vaccination and I develop an immune response that's going to protect me, I have individual immunity. If I vaccinate a population of people, anyone who can be vaccinated, then we develop population level immunity, which can protect people who can't be vaccinated, for example. So let's say that you have 10 kids, 3 can receive their MMR, or 7 can receive their MMR, 3 cannot. The likelihood of those 3 children getting measles, for example, is much, much lower because the other 7 kids have been vaccinated, and it's going to be very difficult for the virus to make its way into that. So that's kind of the concept of herd immunity. I just had this conversation yesterday with somebody. Herd immunity relies upon the number of people who get infected and the number of people who develop immunity. For every disease, it's a little bit different, but typically it's up in the 70 or 80% range. So 70 or 80% of a population needs to have immunity for herd immunity to be able to protect everybody else who does not have immunity. I do not know, and I don't think anybody knows, what percent of the United States population, or even within states or even within counties, have been infected. And it goes back to the iceberg, right? Because the majority of people who have been infected, we probably don't even know that they've been infected, but they still likely have immunity. So Jill asked a really great question that unfortunately we're not going to really know the answer until probably a couple of months down the road and good antibody tests come out and we can do those sorts of studies.
And as of now, there's no antibody test to figure out who's been exposed and who has protection. Is that correct?
It would have been correct a week ago or 2 weeks ago, but the antibody tests are now coming online. And so the industry, commercial entities that develop these tests are engaging with the FDA. The FDA is giving them the go-ahead to start marketing these tests. So they are becoming available. how they're going to be used, that's another question, and how widely available they will be. That's another question.
And what about a vaccine? How far down the road do you think that is in your crystal ball?
In my crystal ball? Well, most of my career I've been working on developing vaccines. And so typically under normal circumstances, at least what history has told us, it can take up to 10 years and $1 billion to make a vaccine. Now, what we've shown with Ebola and MERS-CoV and Zika, and now with this, is it does not have to be that way. When there is focus and there is resources and there is communication and there is a broad community working on a problem, things can move much, much faster. That being said, I still agree with Dr. Fauci from NIAID that we are looking at least a year, if not 18 months, until there is a vaccine that would be broadly available. There are so many steps that you have to take, and in the end, you still have to prove it is safe, and you still have to prove it does what it is supposed to do, and that takes time.
Doc, when you're in the hospital with patients and with the team that you talked about when we first started, take us in that room. What's that situation like? Tell us about what you're all going through and how you prevent from every single one of you getting sick when you're around everybody that could infect you, and what kind of pain are they going through, and how does everybody deal with all that?
Yeah, that's a multi-pronged question that you just asked. So what I can tell you, and it's been every hospital.
All right. Well, it appears we're having a little technical difficulty right
on
now.
A good question. He froze up.
I know.
If he can hear us, maybe he can reset his phone. So we're speaking with Dr. Stephen Thomas, the Chief of Infectious Disease in Upstate University Hospital, and he's been giving us great information. And
we appreciate your guys' questions as well. We'll get to as many of them as we can. I mean,
I'm sure he'll reconnect and we'll get back to those questions, but we'll pop in as many as we can. And then as soon as we're finished with Dr. Thomas, Charlie McDonald is going to come on with us. And Charlie is he's a photographer in Naples, and he's had the disease, or I don't know if I should say he's had it or he still has it, but I know he had it for a while. There were a couple of news stories that they did on Charlie, so we're going to talk to him. And then Janine's going to check in with us toward the end of the show and give us an update on how the shirts are going. That's one of the best programs that they came up with down there to help the people that are working in the restaurant business and also in the hotel business. So we're going to get an update from Janine on all that. And just like that, the doctor is back, and luckily we have a little bit of a radio background, so we can fill in the space there. That was a short commercial break, and now back to the doctor.
Yeah, technology. Okay, so what I was saying was personal protective equipment, right? The face shields, the goggles, the mask, the gown, the gloves. We are always in a balancing act because the supply and the resupply it's not guaranteed, right? So we have to operate under the concept sometimes that we have what we have. So we have to maximally protect our healthcare workers today, but also try to plan for a surge when there are going to be a lot more infected people in the hospital. So about a week and a half ago, maybe about 2 weeks ago, when the number of cases started to do this in our area, we went to universal masking within the hospital. Every patient who could wear one, every visitor, every employee walks around with one of these ear loop masks. So this is a mask that if you are sick, can help protect other people from getting sick. This isn't the mask that protects you from someone else who's sick, right? So everybody wears these for a couple of reasons. One, which you had mentioned before, we don't know who's infected. We don't know if they don't have symptoms. We don't know if it's before they're developing symptoms. So everyone wears one of those. And then when people have to go and see patients, they wear what we call this N95 mask, or they wear the battery operated, what we call a PAPR. It's a big hood with a shield and it's positive pressure there. If you go into the intensive care unit, what you're going to see, and this is kind of unique, it's not normally like this, you're going to see a bunch of rooms. Everyone's got their own private room. The door is closed, right? And you're going to see IV poles outside of the rooms. And you've seen this on, national television shows. You can, the nightly news, you see that. That's not typically what we do. Typically with the tubing is much shorter, but we now are using this really long tubing. We're putting the IV poles outside because nurses need to change things on IV poles multiple times an hour. If the thing was in the room, they would have to put on new PPE every single time, right? So it's lots of IVs, a lot of people, about 60% of our patients who we have in the hospital end up being on ventilators, so breathing machines. Some people need dialysis. Some people need even more intense measures than that. So these are very, very sick people. And then there's about 40% of people who are not as sick. They don't need an intensive care unit setting, but they're having fever, they have muscle aches, they have fatigue, they may have shortness of breath, they have cough. And again, there's no definitive therapy for this virus yet. And so we just have to treat their symptoms, keep them as comfortable as possible, and watch for signs that they might be going in the wrong direction and they need an intensive care unit setting. We have had very, very young people who they were doing okay. So these are people in their 20s. They're doing okay, and then they fall off this cliff. They end up in the intensive care unit. And then after a couple of days, they seem to rebound again. And that really makes everyone feel really, really good when you have a save and somebody bounces back.
And is that what's different about, about COVID, is that, you see this specific people seem to, it's obvious if you have a pre-existing condition that you're going to be at a higher risk for getting really, really sick. But then there's these sort of outliers that don't seem to have a pre-existing situation. We actually had that here in Fort Myers where a DJ got sick, and 39, I think he was, and he did not survive. And as far as we all know, he did not have a pre-existing condition. So you've got people they don't even know they were sick, and then young people who, for no other reason, and end up with a really unfortunate outcome. So any insights on that?
Yeah, there are the, I guess to quote the former Secretary of Defense, there are the known knowns, right? So we know that people that have COPD, or people that have kidney disease, or people that may have rheumatologic diseases like lupus and those sorts of things, and people that are more than 60, 70 years of age, we know that they have a much higher risk of not doing well with this disease and potentially dying from it. But then, they are the known unknowns, which is we know you're infected, but we don't know why you're so sick because you don't have any other medical problems. You're a young person. And those are the types of things that we're trying to look into. So is there a genetic component to this, right? So there's been a lot of news recently about the African-American population and how in some places they are disproportionately being infected and disproportionately having severe disease and not surviving. So is that something is that a genetic issue, or is that just another issue, what we would call these kind of social determinants of health, where people that are in certain socioeconomic status groups, or they're in, live in certain types of environments, always do worse with infectious diseases? So it's a good question. We're trying to figure it out. And it's the question that applies to kids as well, right? So we know children can get infected. We know that they can get ill, but for the most part, kids do very well with this disease. So why is that? Is it their immune system? Is it the fact that maybe their lungs and the types of what we call receptors that you need in your tissues where the virus will bind? Is it that they don't have the same receptors yet that adults have? Is it has something to do with infections you've had in the past? Because there's other coronaviruses that what we call community acquired coronaviruses that circulate all the time. They've been circulating. I mean, we identified they were circulating, 60, 70 years ago. So does it have anything to do with that? So just lots of questions we just don't know the answers to right now.
Doc, are we at any point where you feel like the curve is flattening?
So what we have, you can look at a map of the United States and you can see where the activity is. And basically what you have is multiple epidemics within the United States. You have New York and Jersey and Connecticut. You have Detroit. You have Los Angeles. You have New Orleans. And the dynamics in all of those places are different. The factors that are contributing to the rate of infection, although there are many common factors, there are other factors that make it a little bit different. So it really depends on where you're talking about. So New York State, the governor has said a couple of times that, based on the information he's getting, that it seems like there are fewer and fewer new cases identified every day. Even though the death rate is going up, there are fewer and fewer new cases identified every day. So in this environment here, it is possible that the curve is actually flattening. I'm glad you asked the question, though, because what we have seen before, and you can go back, and there's plenty of literature on this. If you look at the 1918 influenza pandemic, which they believe killed anywhere between 25 and 50 million people, you can look at every single state in the United States and you can see what kind of measures did they take when they first understood that they had a pandemic, and how long did they sustain those measures. Let's just talk about physical distancing for a second, because what you saw in multiple states is they did a great job initially and the peak of infections was low, but then they relaxed too soon. And the rebound of cases was twice as bad as what they had the first time. And again, this is being talked about in multiple places, and it is an absolute real concern, which is going to require people to have focus and discipline and resilience, or what we're experiencing now may pale in comparison to what we could experience in the future.
Fauci said on a Wall Street Journal podcast last week that he kind of judges things by how many hospital beds are being utilized for the virus. And if you see that to slow down, then that's a good sign that things might be flattening. What are you seeing there where you guys are?
Yeah, so we are on so if you look at New York and you look at the curve that shows new cases by day, you see what we call an exponential growth. So it's this kind of curving up like this, right? Almost like a bow. And that's really bad, because what that means is every day, or even less than 24 hours, you're seeing a doubling of cases. The shape of the New York City curve is starting to kind of bend, as we just mentioned, to start to flatten a little bit. What we have where we are up in central New York is we have a straight curve. We have what we call a linear curve. So we're getting the same number of cases every day, 15 to 20 cases new every day. We are not seeing a flattening yet. We're just kind of, and it's a little bit eerie, we're just kind of plodding along, same number of infections, same number of people in the hospital. We have seen a significant decline in emergency department activity overall, but we're seeing a higher percentage of the activity that is there being related to COVID. So I agree with Dr. Fauci. That's one metric that you can use to try to understand what the activity is like. Again, it has to be looked at a local level, because it also reflects what the availability of testing may be. It is possible there are lots of people who were sick, but they didn't get tested because they didn't have availability to testing, or people even who died that they did not determine what the cause of death was, right, because testing wasn't available. So I agree with him, and I would say, again, it has to be taken in the local context.
Is social distancing the answer? Is it working?
Yeah, so I guess the first point, I like the word physical distancing, because I don't want people to be socially disconnected or socially distant from people, right? I want people to continue. We need it more now, more than ever, right? Write your emails, chat, phone calls, FaceTime, have your Zoom, cocktail hours, do all of that. Listen to your show, do all of these things. Stay connected, right? Stay connected. But it's the physical distancing that needs to happen in a very rigorous way. And does it work? We know it works. We've known for over 100 years that it works, not just with with this disease, but lots of other diseases. And we know from, as we talked about before we went on the air, Korea and South Korea and Singapore, and we mentioned San Francisco. There are numerous examples with COVID where strict adherence to physical distancing, early adoption of physical distancing, it works. It absolutely works.
And now, and we like that term better than social distancing. That's a great term. Now that we're in it, as far as things that people can do to mitigate their, chances, we know about washing your hands 20 seconds, using the, hand sanitizer with 60% alcohol. When you talk about the masks, I think we say all the time, you're not supposed to be using those N90. If you're a civilian, just be using a regular mask, your bandana, but that's preventing somebody else from getting it. It's not helping you to the extent that a regular medical mask would. Is that correct?
Yes, you are correct. So not all masks are created equal, and not all mask wearers are created equal. So if you have a source, if you've been able to find the source of a loop mask like this or an N95, know that every mask that you buy that could be used for a medical provider, you are taking from that medical provider. And so some nurse or doctor or respiratory therapist or pharmacist or whoever who is putting themselves at risk to take care of their community, you are taking a mask out of their hands, right? So you're increasing the risk. So that's the first thing I would say. When you look at masks, so the N95 masks or the PAPRs, those are the best. 95% or greater efficacy at protecting the person wearing the mask. Ear loop masks like this one, or the tie surgical mask, those are less. Those are about 60 to 70%, right? And those are predominantly, like you said, from me, if I'm sick, from giving it to somebody else. And then you have the homemade masks, which are probably about 10 to 20%. They're not zero, but they really should not give you a false sense of confidence that you're saying, I'm wearing my homemade mask, which means I don't have to physically distance anymore. I don't have to wash my hands. I don't have to cover my mouth when I cough or sneeze. And that's one of the downsides of universal masking as a nation, is that people could potentially forget. Now, there's a lot of positives, though. Again, it's not zero. It's still about 10 to 20%. But it can also remind people, listen, we're still in a pandemic. We still need to wash our hands. We still need to physically distance. It's not this abstract thought. It's, wow, I'm looking around and a bunch of people are wearing masks. And it's also good to reduce stigma. If you're the one person in the room of 20 people that's wearing a mask, that's one thing. If you're one of 20 people wearing masks, it's a whole different thing. You're all in this together.
Should we in the future never shake hands again? And I mean, things are going to be different. I mean, a guy went to shake my hand the other day and I said, are you kidding me? Get away. No, I mean, we can still say hi, but
right.
I mean, there's certain things that will avoid germs changing hands forever, right?
Yeah. I think, I haven't wrapped my brain around what new forms of salutations will be in the future. But I will say this, I am hoping that this motivates people to become frequent and habitual hand washers for the rest of their lives. Because COVID or not, tons of things are spread every day by touching something or touching somebody and then touching your eyes, your nose, or your mouth. So it's not just this, it's bacterial infections like MRSA. It's, any things that can cause diarrheal diseases, norovirus, things like that. So I don't know what greetings will look like in the future, but I do hope that people really start washing their hands habitually and for the rest of their lives, because it will help in many ways.
What worries you the most, Doc? What worries you the most moving forward?
What worries me the most today is that when people, you can look on social media, you can talk to people in your community. Folks are fatigued, they're tired, they're not, they're being less receptive to the same message that they've been hearing about the need to physically distance. They're starting to see some positive signs that maybe case numbers are going down in certain areas. I am really concerned that people are going to lose their motivation to continue physical distancing. They're going to revert back to old ways too soon, and we are going to see that rebound effect that I mentioned earlier. And that rebound, that curve is going to dwarf what we've already seen, which is going to mean tens of thousands of people dying, and the medical care infrastructure being completely overwhelmed, and the economic pain and suffering that people are experiencing is going to be, much worse. I see a lot of things out there. The cure is worse than disease. Yeah. I can guarantee you that is not the case. I can guarantee you that is not the case.
When you're talking about, the time, and I know it's hard to say, but what is that time frame before,
when do you think it'll end?
Yeah. So like a lot of academic groups, I mean, we're a medical university, right? We have, we educate new doctors, we have researchers. So we have our own curves that are built specifically for Central New York. And I learned a good lesson, because on those curves, we show the worst case scenario, and then we show variations of the worst case scenario depending upon the physical distancing that we see going on in our community. The curve we're not showing, which we're going to start showing now, is what the best case scenario could look like. So the best case scenario would be 70 to 80 or even higher % of the country takes physical distancing seriously, that it is strictly implemented. And if that happens, there is the potential that we can really drive new infections way down, and that we could have a quicker release of these sorts of draconian measures that we're being required to implement. So it is sort of like we haven't really shown people the carrot, right? We haven't shown people what is actually possible. What they look at is they say, oh my God, 3 months, so if we do nothing, this thing will burn out in 2 months. If we do the best thing, it's going to burn out in 6 months. It gets people very deflated. There is another curve, and that curve is, 70 to 80% of the people staying at home, washing their hands, social distancing, only essential visits, food, water, medications. That curve can be shorter, and it can be smaller, and it can result in our ability to get back to whatever the new normal is much quicker.
Well, Doc, we can't thank you enough. The people on the beach are really appreciative of all the information you provided, and we could talk for hours, but you have a job to do, I think, and it's a lot more important than what we're doing down here sitting in the sunshine. And it's been an amazing interview, and we're going to repost it for the people that weren't able to jump on. We had a big audience for you this morning, but it's going to get bigger when they come back and watch it later on. And so thank you very much, and enjoy the snow up there in Syracuse, and have a happy holiday weekend.
Yeah, thanks. You too. Thank you very much.
Thanks a lot,
Bye.
Dr. Stephen Thomas, and we really appreciate his time. That was an awesome interview. What a super nice guy.
I mean, it could have gone on.
Yeah.